OCD used to be classified as an anxiety disorder. Now it's got its own separate category in the DSM because it's in a different part of the brain than an anxiety disorder. But prior to that knowledge, so people who had an eating disorder, about 40% had like some sort of anxiety, or like 2/3 had some sort of anxiety disorder going on. Half of that number is OCD. So it's like really, really high.
My name is Isabel, and I'm a licensed clinical social worker and certified eating disorder specialist with Into Place Therapy in Arizona. Today, I am with Bethany, who is a licensed professional counselor and a certified eating disorder specialist, working virtually as a therapist in Arizona, Texas, Nevada, and soon to be Washington.
Soon to be.
And she's working with people 8 years and older. Is that right? Okay. Bethany has a million specializations that I would love to brag about, but we don't have time. But please look her up. It's pretty awesome. But today, I just want to highlight that she's worked as an OCD therapist and an eating disorder specialist across all levels of care. And then I also just want to clarify, when I say OCD, I'm referring to obsessive compulsive disorder. So I first met Bethany at an outpatient clinic that we worked together at, and we worked at an intensive outpatient program together. And then we worked again together at a residential eating disorder program.
Can't get away from me.
Yeah. So we've gotten to know each other quite a bit, and you're one of the therapists that I've learned the most from. So I really, really appreciate all the things that you've taught me in all those settings. And I just want to highlight specifically that I think you're a very diligent and thorough clinician. You do your homework, you look at the person in front of you, and you're always trying to learn more, which is part of all your specializations and certifications that you have. You do the work is basically what I'm trying to say. So thank you for being that kind of therapist in the world. We need it. And I'm really excited to have you here.
Me too. Thank you for having me. I appreciate it.
So let's just start with your story. Can you share a little bit about your background and how you ended up being both an eating disorder and OCD therapist?
Yeah. It kind of fell into my lap, I would say. So I originally started out in grad school being like, I want to work with kids. I want to be a play therapist. I would specifically want to work with trauma. And so I worked in foster care for a while, the foster care system. And then I worked at a substance use place for a while because like maybe foster care is really hard. And then I moved to working in a domestic violence agency where I got my registered play therapy certification. And I happened to have a kiddo who was like really struggling with binge eating, but they were 5. And so this was something that like there were no programs for in like the area that I was in. And then also at the same time, the family was very much like underprivileged and could not afford any kind of like specialty care. And so I was like, well, I'm going to like learn a lot. And I really dove in and, you know, in collaboration, obviously, with like medical providers that they were seeing, and ended up doing a lot of parent work too, because since the kid was so little, it was a lot of like parent stuff as well. And just like kind of around their trauma. And then I really started to enjoy working with eating disorders and worked a lot. And then I moved to private practice and got to like really explore that more and do a lot more learning and research and development and collaboration. And then I kind of just was like, this is now what I'm going to do. And it's just kind of really started specializing in that, working in that primarily. And then OCD was also kind of something that fell into my lap too. As the residential we were both working at was kind of, we were looking for more of an outpatient experience because residential is like really hard working there as a therapist. And so there was a OCD private practice that was asking for an eating disorder specialist. And because of the comorbidities, there's just so much overlap. And so I applied for that job because I was like, sounds like a plan. I don't want to be in residential anymore, unfortunately. And like really just opened my eyes to just, I mean, OCD is not what I thought it was whenever I started working there. I don't think we learn enough about OCD in graduate school or just like professionally sometimes, unless we really seek it out. Um, and now I would say like my favorite clients are the ones that have OCD and eating disorders. They're really, that's really just what I enjoy working with. So,
Mhm. And you just said it yourself that there's a lot of overlap with OCD and eating disorder. And I don't think, a lot of people recognize that. I think in some ways they're similar enough where that could be confusing or missed by a clinician. So, how common is it for someone to have both, and what is that overlap?
Um, so like statistically speaking, and I think we need to redo this particular research because OCD used to be classified as an anxiety disorder. Now it's got its own separate category in the DSM because it's in a different part of the brain than an anxiety disorder. But prior to that knowledge, so people who had an eating disorder, about 40% had like some sort of anxiety, or like 2/3 had some sort of anxiety disorder going on. Half of that number is OCD. So it's like really, really high.
Yeah.
And it is often like really missed, I would say.
Mm-hmm. And you just said different part of the brain, and I'm just a brain nerd. So can you can you unpack that?
Yeah. So with OCD, it's more so found in like the orbital frontal cortex and some like basal ganglia stuff, as well as the anterior cingulate cortex. So it's in just like a different section of the brain, which I think until we had that knowledge, like it made sense that we put it in the anxiety disorder kind of category because it really just like feels like anxiety. But it is like kind of lighting up a different portion of the brain than like a typical GAD diagnosis would.
Okay. Yeah, that makes a big difference in treatment.
Yeah. Yeah. And I think the more we discover about it, like unfortunately we're still learning. I think with anything in psychology, we're still developing and learning. And so like that is like a current like new research situation that I think the more we learn about it, the more we'll be able like differentiate for people really. But brain scans don't come with diagnoses, unfortunately.
Sure. They're not that structured or helpful to us. Now, a lot of people associate OCD with like fear of germs or fixation on cleanliness. And obviously, I don't have to tell you, it's a lot more than that. But how does OCD show up with things like food or body image or exercise?
Yeah. I think OCD is just so much more complex than what even I understood as a clinician going into it. But I mean, there's like so many different subtypes of OCD, like harm OCD, or obviously contamination or just right is kind of the more traditional stuff that we think about. But there's some like taboo subjects like pedophilia OCD that obviously like don't get talked about a lot because people are so worried that like I'm gonna go to jail if I talk about this or I'm gonna get reported. And then we have like contamination and like emetophobia is considered a subtype of OCD, which I think is confusing for a lot of people because it's currently classified as a phobia. And I mean, so emetophobia, contamination can impact food stuff a lot, but I would say emetophobia is a big one of like, I'm so worried that my food is going to make me sick or, if a restaurant's not going to fully cook my food, whether that's contamination or emetophobia, it just kind of depends on what the actual fear is. But there's also in OCD just magical thinking. And that can loop in a lot of different food stuff too. I mean, I had a kiddo who like couldn't eat certain foods on weekdays for fear that the routine is off. And so it's like that doesn't really have anything to do with one or the other, which is why it's a magical thought. But it just kind of loops in food often. I would say a lot of just rights and like perfectionistic OCD can kind of attack body. There's also like obsessive compulsive personality disorder that I think has a lot of comorbidities with eating disorders as well. But harm OCD, I would say, like we look at orthorexia as an example. That is something that I think the OCD and the eating disorder community are kind of like fighting over right now, which it has roots in both. But with that one, it really is like about harm. of like, what if I put something into my body that isn't like pure, clean, perfect, that I'm doing damage or harm to my body. And so that would be very similar to like a harm OCD experience where I'm worried that I will do something that will cause harm or some harm will come to me. And so a different harm OCD thought might be, did I run over someone just now in my car? And I need to go back and check and make sure that that bump that I felt in the road wasn't like a human. So that would be kind of just different ways of looking at it. But ultimately, it can show up in a lot of different ways. Like food's a huge part of our life. And so is our body, like it's our packaging. And so it can get looped in a lot of different ways that health OCD is another one of like, there's a lot of body monitoring and scanning for symptoms and food. I mean, God, like we're so targeted for like diet culture stuff and just like, oh, this new food now causes cancer potentially. And so a lot of clients with like health related OCD are going to eliminate a lot of foods from their diet due to just like reading a singular research paper or a news article or something on Instagram that said, like this food causes cancer. Now I need to cut it out for my entire life. And so it really can show up in a lot of different ways. So it's so much a part of our life.
Mm-hmm. I like that idea of our bodies packaging.
That's what I call it. Yeah. It's like the packaging we come in.
And then on the other side, of course, like some body and fixations or food sort of obsessions and rituals like seem like OCD, but they're not. Yes. And so how do you help people unpack kind of what's coming more from OCD and what's coming more from eating disorder?
Yeah, I think you have to get down to like what is the function and what is the fear. And so when it comes to the fear, when it's like a more of an eating disorder experience, with the exception, I would say, with ARFID, because then that gets into like some very severe murky waters. But if the fear is around like gaining weight or my body changing, and it's about like weight, shape, size, that's going to be more of like the eating disorder experience. And when it comes to OCD, it can be so many different things. But if it kind of really is that fear of my body changing and that feels outside of my control, that is more of an indication that it's going to be an eating disorder. When it comes to ARFID, people can have both OCD and ARFID. I think the most common overlap there is going to be if we have like emetophobia, fear of choking or vomiting, and then we have ARFID as well. Oftentimes, how I've seen this is it starts out as OCD, and then because it has a lot of compulsions around food, we then develop ARFID over time. So that's kind of been my kind of anecdotal experience with that. So, but I am curious to see how that's like a new diagnosis, how that develops over time. So, I think the most predominant co-occurring is going to be anorexia and OCD. It can be with any diagnosis as a whole, but it's so much more common that it's anorexia and OCD overlapping.
And then you mentioned ARFID, and can you just maybe talk a little bit more about what it is? Because I feel like that doesn't get talked about.
It's definitely new, right? So ARFID is avoidant food intake, or AR, avoidant restrictive food intake disorder. I always skip one letter at one point. And so that one is kind of broken up into 3 different subtypes. So that's going to be, the first one is, like the one that I just mentioned. So fear of some sort of negative consequence happening when I'm eating. So that could be I'm fearing of choking, vomiting, GI distress, like bodily related issues, could be allergies too. I've seen contamination OCD develop into ARFID of like, I'm so afraid that my food is being contaminated or that it may be contaminated that I'm not going to be eating or I'm going to avoid large amounts of food. And then we have just like kind of lack of interest. So they just kind of have a naturally lower kind of hedonic reward system when it comes to food. So like when my body eats food, I get this like overwhelming, like I'm so happy, I feel full, it feels great. I get this dopamine and serotonin rush. And those clients with that particular subtype of ARFID just don't have that as much. They would much rather be doing literally anything else than eat. And it feels like a chore. And then you have the other subtype, which is very common in like kind of sensory processing or the autism population, which is sensory issues with food. And so that one is like, I would say that one's much more challenging because we don't habituate very well to sensory issues. And so, like, when we're doing those exposures, it's really working with that disgust response that our body gives us and really trying to work on values more so than we are like, the more we eat it, it's going to get better, because it may not. Especially if, like, the sensory processing, the autism is present there too. Like, it's much more harder to habituate to those experiences.
Mm-hmm. And I imagine, with the sensory piece, you have a lot of experience with kids and play therapy, and I would imagine that's helpful.
Yes. Yeah, I think ARFID is especially something I'm very passionate about because it's new. So there's not many treatment programs that have like kind of developed protocols around this particular population. I think we're working towards it and we're doing better. But ARFID is one that shows up much younger than any other eating disorder does. So like I've had clients that are like 5 with ARFID. And so that can't look like traditional eating disorder therapy because they're 5. There has to be way more of a parental like kind of involvement than even like FPT, just because like they are so little. And to get buy-in, because a lot of this population, when it's developing so young, their insight into like, why do I need to work on this is like just not there, because like developmentally they're not, that's not what our brains are there yet, especially if we're malnourished. And so really, I mean, their language is play. So really building in like play into the experience. So we don't do exposures, we do science experiments. We don't do psychoeducation, we like make books and we play and we use puppet shows and like really kind of tailoring it to their developmental level, to make it just like more fun. Because if something is more fun, you're more likely to do it when you're little. So, and then also just like like working with parents to make sure that follow through is happening too.
And you mentioned FBT, family-based therapy, which is like evidence-based intervention for teenagers. And you also said, right, there's like situations where it's not helpful. And so when an adolescent has maybe OCD and eating disorder, do you find it helpful? When do you not?
I think it just depends. It definitely is evidence-based, but I would say it depends on the family situation specifically. So with an eating disorder, there's a lot of family stuff happening. And so if the parent has their own stuff going on, so like let's say working with a kiddo with ARFID, but the mom has like some health OCD stuff because OCD is also very genetic. And so like there's a very high likelihood that if there's a child that has an OCD diagnosis, then one of the parents likely does too. So if my kiddo that we're working on has like maybe a emetophobia and ARFID, and the mom has health OCD or harm OCD, mom might be a barrier. Because she's so worried about, well, whatever food exposures we're doing, that food might cause harm to my kid. They can't eat that. And so in that situation, FBT may not be the best approach. Or like you really have to work on doing a lot of family-based intervention prior to even get their kind of like buy-in, or just like recommending that the parent do their own work too. And that's a situation where it's like OCD, but it could also be like the parent has some sort of like body image stuff going on for themselves and like have a lot of diet culture stuff. And so they're worried about their kid gaining weight and how that may affect them socially. And so they might become a barrier for that too. So it really just depends on what the family dynamics are. And if like they don't also, if like the family is very tense, FBT may not be the best approach either, because like you're just going to get more of a power struggle every single meal, which is like not what we're trying to do.
Mm-hmm. Yeah, that's not helpful or doesn't feel good for anybody. And you mentioned, the role of the parent in treatment, and obviously they're the biggest player in their kids' lives. And so I know sometimes like enabling can unintentionally can show up both in an eating disorder and OCD. And so what do you see there?
Yeah. So in OCD, realm, we call that accommodating. And so, which is really, I mean, if your kid is in distress, right, as a like just basic biological response, we want to help them. We want to get rid of their pain and their distress, and we want to make them feel better. That's just like literally every parenting book ever, honestly. And just like very biologically pre-programmed. But when it comes to like OCD or an eating disorder, um, by giving that kiddo, teenager, kiddo, whatever, what they want, quote unquote, I am unfortunately making them sicker. And that's like really, really icky and hard to sit with as a parent. And like, but at the same time, like you're just doing what you think is best. Like you're just trying to survive. And so we're working on reducing those accommodations over time for parenting, which there's a specific kind of curriculum and like model that a lot of OCD therapists use, which is called SPACE. So SPACE stands for Supportive Parenting for Anxious Childhood Emotions. And they've developed a protocol specifically for ARFID as well. But it is essentially where parents have kind of two kind of general responses to the it's written for OCD, so to the OCD. And it's one is to protect, which is where a lot of parents tend to fall into, is like, no, I'll make sure that you don't have that experience. I'll take this away from you. I'll, tailor our life to where you don't have to experience this challenging thing. And then you have the kind of, it's called demanding. I think that word is a little harsh. So I usually say like, it's more of an expectation. Like I believe that you can do this thing. I believe you can conquer this hard thing. That being said, they're expecting you to do it. And they're just like, no, like, just go do it. Pull off the Band-Aid, go do it. The kid experiences that though as very like dismissive, which is why we say the word demanding, unfortunately. And then those parents end up usually marrying each other. So there's usually like one parent is holding the other space. When they're both coming from a very good spot, but we're wanting to like kind of marry those two approaches because the protective parent, unfortunately, the subtext of all of those accommodations is, I don't believe you can do this thing. You're too fragile. You're too fearful. Like you really can't tolerate these hard things. And so we're trying to marry for the protective parent. They're really good at validating the emotions of the kiddo. And the demanding parent is very good at kind of restating their belief in the child. And so we're trying to marry those two things. And then same with eating disorder too, like the more we accommodate the eating disorder, the worse they get. The more we try to just say, just eat the food, just do it. Like we're missing a lot of it. So it's kind of working to find that middle ground and find that balance to both challenge the kiddo, to get them to believe in themselves, and then also, supporting them emotionally.
Mm-hmm. Yeah, there's almost like this resilience building piece in there, which is awesome. And, maybe for kids, since we're focusing on that right now, like what are some early signs that a kid is struggling with OCD and eating disorder?
I would say the biggest thing that we often see is reassurance seeking. So like kids have fears, that's just developmentally a part of the experience. But when a kiddo is like constantly coming to you saying, like let's say I was afraid of a fire happening. And like the first time I learned about it, you walked me through all of here's the fire alarm, here is the sprinklers, here's like how to call 911, here's how close our fire department is, here's like you're kind of walking me through these safety prevention methods that you have for fires. Maybe a couple of times of explaining that I'm good to go. I'm not worried about that anymore. That's kind of like typical development of what we see. With OCD, it's just the hamster wheel that never stops going. And so they'll keep asking, they'll want you to show me the fire system again, show me the fire system again. And it's almost like their brain is just like not accepting the answer. And it's because that reassurance seeking is the compulsion. So every time I have that fear of what if the fire happens, will I be in danger? Will I get hurt? I need mom and dad to come in and tell me that everything is going to be okay, to then give me that very brief relief. And then, unfortunately, every time that I do a compulsion, it's reinforcing to the brain that that obsession is the scary thing. We should think about it more. And so then it happens more. And then every time I go through that cycle, it's making that fear feel worse again. And so parents often get looped in because they're just trying to make their kid feel better.
Sure.
So I would also say, like, I mean, for eating disorders, that could also reassurance seeking is present in eating disorders of, do I look fat in this? Do I look okay? But more so around like body image stuff. The younger they are, I think the more they involve their parent in the experience. And we are seeing eating disorders a lot younger, even the body image ones, just because society sucks. So but like, asking their parents, like, is this food going to make me fat? Is this food good for me? Is it healthy? That would also might look like compulsively Googling stuff. With OCD, that might be, like, what happens if you get sick? Like, what is Ebola? What is, maybe like I'm researching like diseases. Google searching can come in a lot of different experiences. You could have like sensory motor OCD where like I'm so fixated on a physiological experience like breathing. And what I'm worried about, like I'll never not be able to pay attention. And so I might be Googling like, how do I stop paying attention to my breath? But with eating disorders, more so along like body image, food, probably calorie content or healthy, not healthy, what will make me fat, what will make me thin. And I mean, ultimately, if like with eating disorders, with behavior changes around food is like a huge indication of like if your kiddo's favorite food was Chick-fil-A and then suddenly now Chick-fil-A is bad and I can't have Chick-fil-A. A lot of labeling of foods is a red flag indication of, starting to say just foods are bad or icky or gross when that hasn't been my like lifetime experience with my kiddo. I mean, there's just a lot. So it can be confusing and it's hard for parents because that's like ultimately we do live in a society that, this is how we talk about food. And so it can be just very easily missed, unfortunately.
Yeah, and I imagine with that age group too, it's like they're changing anyway, and so it's sort of hard sometimes to differentiate what's them growing up and becoming a dull person and what isn't. So switching gears maybe to adults, what are some early signs there?
For eating disorders or OCD?
For both, sorry. Yeah, for both OCD and eating disorders.
I mean, so with OCD, symptomology, I would say women are more likely to develop OCD at any point in their life. Whereas men were more likely to see it kind of happen at a younger age. Doesn't mean they can't, but for women, it's more likely to be a lifespan situation of where we're at risk of developing OCD. But depending on the kind of subtype, the difference between OCD, I would say, is OCD is ego dystonic, which means it's against the self. So these are going to be clients who come in complaining about like, I just have these thoughts that bother me so much. I hate that I'm thinking about this. I wish I could stop my brain. And that's like very different than an eating disorder because an eating disorder is aligned with self and goals of like, no, I do want to be thinner. I do want to, if like, let's say this is the orthorexia piece where it's like kind of sus in the middle. But like, I do want to be able to like control I'm putting in my body and I don't want to cause harm to my body. So, but if like thought content feels like very kind of just overwhelmed by, stuff like for OCD, like just stuff that maybe I'm not wanting to be thinking about necessarily, not like my work stress is so overwhelming, but like constantly having thoughts about like, well, what if someone gets sick around me? I need to make sure that I'm not around them, or I need to avoid this. With eating disorders, like constant thoughts of food and being just plagued by that. I can't always thinking about my next meal. What am I going to do? How am I going to prepare? Or my body. But yeah, I would say because of the ego dystonic stuff with OCD, like clinically, people who are coming to therapy you're going to see a higher incident of clients with OCD because they are so distressed by those thoughts. So as a clinician, it's really important to screen for that of like what is GAD versus what is OCD, because oftentimes clients are getting misdiagnosed with OCD or with GAD when it really is OCD and generalized anxiety disorder. Thank you. And it's really honestly very bad because for OCD, research shows us that it's better for clients with OCD who have never gotten treatment at all than got the wrong treatment, which super sucks, because ultimately therapists end up doing compulsions with the client. So a lot of like traditional CBT work that we do, like thought stopping as an example, is a compulsion. And so I'm teaching clients, I've definitely been guilty of this before when I look back clinically about clients who I diagnosed with GAD, and I was like, oh, they definitely did not have GAD the more that I've learned about OCD. And we end up just like ruminating out loud with them. So with OCD, the compulsions are more likely to be mental than physical.
Oh, okay. Yeah, that's a big difference.
It's very tricky.
Mm-hmm.
Yeah. So with GAD, that or generalized anxiety, that one is just like having like my catastrophic thoughts about like general life stuff. And there's a lot of here and now context. And it's gonna be a lot more like free floating anxiety. So let's say, I'm worried about like I'm moving right now. So I'm worried about the move and like how am I going to handle that and the stress and then bringing cats to Texas. How are they going to deal with that? And when it's done, I've moved on to like a new thing. And now my free floating anxiety has more to do with I'm working remotely now and like what's that going to be like and so but it's very much like in the here and now context, whereas with OCD it is not relevant to the here and now context. So things in the here and now might trigger me, but like harm OCD as an example, the like here and now of feeling a bump is not a relevant indicator that I've hit someone with my car. And OCD tends to be a lot more in themes. So like harm, pedophilia, emetophobia, just right. Whereas GAD is much more free floating.
Gotcha. And the content is sort of time limited.
Yes. Yeah. And with GAD, like reassurance seeking is prevalent, but I might move on with a couple of reassurance seekings of like, no, I'm safe, I'm fine, it's okay. Takes me maybe a couple of times and then I move on. Whereas OCD, like I'm just constantly needing that reassurance. It's never good enough. I'm always coming back to this thought. And I think as a clinician, that's a really important differentiation to make because it takes, I think, over a decade for clients with OCD to get the proper diagnosis. So that means they've been in treatment for like usually over a decade before they get the correct diagnosis. So, and that's like a lot of grief work, honestly, that we end up doing when we see a client for the first time and give them the appropriate diagnosis.
And you're bringing up a really good point of treatment being completely different for OCD than GAD. And so what should treatment look like for someone with OCD and eating disorder so people know that going in?
So with OCD, the appropriate treatment is ERP is usually like the gold standard treatment is what we call it. It's also brief. Like OCD treatment is not meant to be like years longs of talk therapy. It is a more brief model of therapy. Another one is called inference-based cognitive behavioral therapy, so ICBT. You can have a lot of like adjunct therapy models like ACT, acceptance and commitment therapy. I'm using a lot of acronyms, and other kind of like mindfulness-based therapies type stuff. But ERP or ICBT is usually like the meat of OCD work. And so with ERP, we're kind of using response prevention techniques that are the opposite of a lot of traditional CBT techniques. And then we're doing exposures to kind of teach our brain that the feared consequence, like we're trying to reteach our brain that it's not going to happen without saying that it's not going to happen, because then we're reassuring ourselves. So I like the inhibitory learning model approach to ERP compared to like habituation. Habituation is we would use like a SUD scale or subjective units of distress. I love me some acronyms today. Where I would like maybe have clients like rank their fears on a hierarchy and say, so like, okay, so we're going to challenge like level 1 fears today. And we slowly work up the ladder. And just kind of we're hitting it repetitively, which it's effective. But the issue with the habituation model, in my opinion, is like life is not based on a scale. And so when a client maybe, let's say we're working on like level threes and a client is experiencing in real life like a level seven fear, and they're like, oh my God, we're only in level threes, I can't handle this approach. It kind of reinforces that these fears are really scary. Whereas the inhibitory learning model is, I'm not having you rank any of your fears. We're just kind of going based on like what is like most kind of bothersome to you, which like most limiting to your life. And then we're not ranking anything because ultimately when I'm ranking something, I'm confirming to my brain that like this is something to be feared. And with inhibitory learning, we're kind of reteaching the brain that I've got this, it's okay, without saying those words. And then with just eating disorder treatment as a whole, I would say that one is a lot more nuanced because it could just be so many different modalities that can be utilized. Like a lot of clients with eating disorders have trauma history, so trauma modalities might be warranted. DBT acts as again CBT, so like thought reframing is valuable in eating disorder work because we have to target some of that like learned diet culture stuff and learn how to kind of get to a neutral place about our body. Whereas thought reframing with OCD is not advised in any way. And I would say for eating disorder care, the one thing that I don't love is reassurance in any eating disorder work or with OCD as a whole. And I think I see this a lot sometimes of people are telling the clients like our bodies aren't going to change, you're not going to gain too much weight, like don't worry. And I think that sets the client up for relapse with eating disorder because like they're in treatment, their body is going to change. We also don't know where their body is going to land in recovery, like long term. And so kind of promising them that, like, no, like you're going to stay in this quote unquote society accepted range, I don't think is super fair. So in that particular way, I don't engage in a lot of reassurance seeking for either treatment model or either diagnosis kind of treatment. But I would say with eating disorders, ultimately, both can be a barrier. Like, so if a client has both, it really is looking at like what is serving as the primary. I think treating both eating disorder and OCD at the same time is like best case scenario. But it's really hard to find clinicians that are trained in treating both. But like, if a client is malnourished, that is going to prevent them from being able to like maybe just emotionally tolerate any type of like ERP work with OCD. And same thing with OCD, like the eating disorder, they might be wanting to keep around because it numbs out their thoughts. So they're not having all these distressing obsessions all the time because I'm kind of just, so I can only focus on food and I'm like really happy about that. So the more we can treat them simultaneously, the more effective the results are. So, but there's not tons of research in that, unfortunately, and I wish there was. But there was one like kind of naturalistic study that was a very low, like setting population situation, but it was like way higher results if you treat people with the co-occurring OCD and eating disorders at the same time for both than if you just kind of segment it like one after the other. But right now, how a lot of like residential facilities are set up is they're not capable of treating both. Just like we're not trained, or it's very like, here's OCD therapy, here's eating disorder therapy. And I think that really stinks for clients because they end up being in treatment for a longer process than what they maybe need to be.
Not super sustainable all the time model that's used. You should open up a residential facility. That's combo of CCTP. No thanks, you doing that. So we talk about this for kids, but for adults, like friends and family often want to help and they're not sure how. So are there any like do's and don'ts for loved ones of people struggling with an OCD and eating disorder?
So, I mean, it's a curriculum that's developed from a parenting perspective, but realistically, the crux of it is universal. So like, from like a sharing perspective. So my family system is like got a lot of OCD up in it. And so from like let's say my brother has OCD. And so I can work on as a sister by not accommodating him in like various situations of I previously would allow him to like avoid a lot of stuff and be like, oh, well, he's so busy, he's so stressed, I'm not gonna kind of bother him with these things. And now I'm like, no, I'm not going to be doing that. I will in fact be calling you with this hard thing, because like this is our dynamic and I love you and I'm going to um, you know, allow you to sit in this anxiety rather than like help you avoid it. So the approach is universal for any type of loved ones. And then I think when it comes to an eating disorder situation, a lot of learning I think is really helpful. Learning about like diet culture as a whole, and really doing some work of like, it's not helpful to talk about like body image and clean eating and my intermittent fasting diet or whatever. And I think that's a really big way of just providing support. I think normalizing and like also being able to treat them like a regular person. I think oftentimes when we're like very in the treatment process, like it's all about my eating disorder, it's all about my OCD, but like there are people outside of this. And so being able to just like hang out with them as a human and support them outside of this kind of stuff that's happening too, and allowing them that space to just be themselves is also really helpful too.
That's a great point, because I think sometimes when someone's struggling with OCD and eating disorder, that takes up so much space and can become an identity forcibly. And so
Yeah.
kind of being someone who reminds the person of everything they are outside of that is
Yeah.
important.
One of my favorite things to do with clients is like, let's say a kid doesn't want to go to school, or like someone doesn't want to go to school. I'll ask like, so what, I mean, I could assume that this is like the eating disorder or OCD talking. But I'll start asking like, what's the percentages of each? Because realistically, there is a percentage of my real self that's like, I don't want to go to school today. Like, I just don't. It's like not the vibe today. But then there's also maybe a percentage of my eating disorder and a percentage of my OCD that's also playing a part in that too. But like making space for, no, like your real self is in there too. And even sometimes when it is aligned, it's still not going to be what we choose to do. But, also just like checking in on their real self, because it can be kind of crummy to feel like everything about me is these disorders.
And that's a great way to kind of get to know yourself too, and especially if you feel like you've lost yourself in the process of developing OCD or eating disorder. So I like that. And obviously it can be really hard and scary to seek out help if you have OCD and an eating disorder. So where could someone like start that process?
Yeah. So I would say for OCD treatment, the IOCDF is the International OCD Foundation. It is they have like a directory of providers. That being said, once again, finding the overlap of the therapists is really stinking hard. There's very few. So I work in Scottsdale currently, and I have clients that have driven from like Goodyear, because like there's just not many providers that specialize in the co-occurring treatment of both, or that see littles too. But the IOCDF is a really good starting point. Eating disorder therapists, I think, are a little bit easier to access, which is like wild that I say this now, because I used to say the opposite. But I mean, Psychology Today and filtering like who's treating eating disorders, I usually always ask also like who, like where is your training from? And like why do you say you specialize in the treatment of eating disorders? Because I would say I've run across people who are like, oh, well, I treat the trauma that's underlying the eating disorder. And that's how I say that I specialize in it. And it's like, okay, so absolutely there could be some trauma that's underlying with an eating disorder. At the same time, if they're malnourished, like hitting the trauma is not going to be like where you get any traction. And so I always look for clinicians who work in multidisciplinary teams. So if like therapists are like, yeah, I work with dietitians, I work with medical providers, that's usually like a green flag, because they're aware of like staying in their scope and practicing within that multidisciplinary, and getting your body healed on all fronts is really helpful. Obviously IADEP, International Association for Eating Disorder Professionals, you and I both have the CEDS certification. So that's another way to show that like clinicians have done a lot of education and training and studying, honestly, and done a lot of supervision in working with eating disorders. So I think those are good starting places. They're not the only places for sure, but they're good. So unfortunately, with either of those, there's not a lot of like buttons on either of those like directories where you can say like eating disorders, OCD. So it's a lot of doing your own research and finding that overlap. I think a lot of people will end up having to do kind of seeing two different therapists, unfortunately, because there's not tons of clinicians that specialize in both. And with that, that's also totally fine. I've done that with a few clients here as well, especially when I first started working at Calm OCD. There was a lot of therapists that had already been working with clients who had an eating disorder. And so they would treat the OCD and I would treat the eating disorder. And that is also effective. There just has to be a lot of collaboration with the therapists.
Sure. And when people are getting help, obviously there's virtual is one way to go, and then in person. Is there any sort of benefit to one over the other, or do you see them both being effective?
I would say they're both effective. For eating disorder care, I do want there to be some sort of in-person piece, whether that's like the dietitian or the medical provider, to kind of just ensure like accountability. Because if I can only really see you from like, here up, and eating disorders are egosyntonic. And so as we're working on recovery, if, you've relapsed and we're not being maybe the most honest, or you're really like concerned about judgment or fear or whatever's going on, I don't want to admit to this. Having some level of accountability is really important in treating eating disorders, I would say. For working with littles, so I used to treat like 3 and up, since I'm a play therapist. I don't love doing in-person or virtual work with littles. I think it's just really challenging. I did it during COVID. It was a function of my existence. It's not my preference. I know that there's really great clinicians that do it. It's just not something that it just really hurts my brain. So, but I would say that there's benefits in both. You just have to have some sort of accountability piece for the eating disorder.
And just like you said, there's really few therapists who specialize in both OCD and eating disorder. You're one of them, and you're also operating out of many states, which is so cool. So tell us a little bit about your work and where people can find you.
Yeah. So I currently work at a private practice called Calm OCD. And so I'm working remote. Well, I've got like a week and a half left of in-person stuff as I'm transitioning to moving back to Texas. But I will see clients virtually from Texas, Nevada, and then Arizona, and then eventually Washington, hopefully. But they can find me at Calm OCD's website. And I'm also on Instagram, funnily enough. Which is like at Bethany Bosier LPC. And then I'm also listed on like the Association for Play Therapies like registry as well. So I'm in a couple different like places to find me too.
Mm-hmm. Awesome. And we'll make sure to include your info under the video too, so people can find you. But Bethany, it's been a pleasure. Thank you so much for coming. You're super knowledgeable, and I appreciate your time.
Thank you for having me.